This is an evidence-based approach to terminal ventilator withdrawal. My name is Margaret Campbell, and I'm a professor in the College of Nursing at Wayne State University. For more than 20 years, I've been studying dyspnea at the end of life, and this presentation is part of that research trajectory. We will identify the processes that comprise ventilator withdrawal, along with how to ensure that the patient is comfortable. Any special considerations under the COVID-19 pandemic will be illustrated by yellow highlighting and underlining in subsequent slides. There are two commonly used methods. Terminal extubation refers to a one-step process in which the ventilator is turned off and the tube is removed, all in a single step, compared to weaning, where there's a staggered reduction in oxygen and ventilation, and subsequent extubation in most cases. Under the COVID-19 pandemic, it may be prudent to maintain the endotracheal tube in order to minimize droplet contamination that can happen during extubation. If the RN or respiratory therapist are using a very high level of protective equipment, then perhaps the patient can be extubated. Ideally, we do want to remove the tube whenever we can because that is a source of patient discomfort. Patients undergoing withdrawal are not the same. This is a heterogeneous population. Some are awake and aware, others are cognitively impaired, some are unconscious, and then there are patients who are brain dead. And the risk of respiratory distress varies based on ability to understand what's happening physically. So naturally, the patients who are fully awake will be at the highest risk, and the patients who are brain dead are completely unable to experience distress. What we need is a patient-centered, evidence-based approach, which is standardized but considers the individual patient differences. So an algorithm affords standardization, and at the same time, the decision trees within an algorithmic approach allow us to modify the approach to the individual needs of the patient. What else is needed is an objective measure of patient respiratory distress, because most patients undergoing ventilator withdrawal are not able to give us a dyspnea symptom self-report. This is the respiratory distress observation scale. It has 8 variables that you can see in the left column, and each variable is scored from 0 to 2 points. The points are then added together to give a total score that ranges from 0 to 16. 0 represents no respiratory distress. 16 is the worst possible respiratory distress. This scale is valid and reliable and has been used across patient populations and across patient diagnoses, and is particularly valid under the context of ventilator withdrawal. The RDOS has cut points that have been established through clinical research. Scores ranging from 0 to 2 are no patient distress. 3 is mild distress. Scores between 4 and 6 represents moderate distress. Scores 7 or higher are severe distress. During ventilator withdrawal, our goal is to keep the RDOS score at 3 or less. Before we talk about the processes for the patient, let's talk about the family. Often, families are at the bedside during ventilator withdrawal, and they witness the process and possibly stay with the patient to witness the eventual death. Clearly, under our current COVID pandemic circumstances, this might not be possible. I think nurses have the opportunity to be very creative here in how to let the family participate. With iPhones, iPads, FaceTime, distance technologies, it may be possible for the family to be nearby, but still able to witness what's happening with the patient and or interact with the patient before the vent is withdrawn. If it's not a COVID-19 case, then we do need to give the family as much latitude as would be normally indicated. So preferences to be at the bedside, preferences for any chaplain support, private time for last rituals, and if the family's not at the bedside but staying in the hospital, where can they be, and who's going to be supportive of them. Other suggestions about the family: describe this process using lay terms. Avoid saying pull the plug, for example. A phrase I have always found helpful is to tell the family that we're gently and carefully going to turn the ventilator down over a period of minutes to allow natural breathing. We're also going to be observing the patient closely in order to watch for breathing discomfort, and we'll treat with medications. If the tube is going to be maintained because of droplet contamination concerns, this is not customary to leave the tube in. So you're going to need to explain that to the family so that they understand the risk to everyone in the room if the tube is removed because of coughing and a spray of possible droplets. If the family is going to witness the withdrawal, then we describe expected patient behaviors, any physical changes, any noises, any coughing. If the family is staying with the patient, then what are the permitted family behaviors, if any, under COVID? And likewise, what kind of questions might families ask? A common question is, how long do we expect that the patient will survive? Duration of survival is dependent on illness intensity. Patients who have multiple concurrent organ system failure, especially if they're using one or more vasopressor drugs, will likely pass away during the withdrawal or shortly thereafter. Likewise, patients who are profoundly hypoxemic. Most patients die within 24 hours if they don't fall into those high-intensity illness groups. For patients who have neurologic disease only and no other organ failure, they may survive for days after the vent is withdrawn. So our process can begin as soon as 24 hours in advance if we know. If the patient has very wet lungs, then there's an opportunity to diurese them if the kidneys are still functioning. Similarly, we want to restrict fluid boluses beginning when we know that we're planning a ventilator withdrawal. If we're going to extubate the patient and there's a risk of post-extubation stridor, 24 hours in advance, we can begin dexamethasone, 4 milligrams IV every 6 hours. Immediately prior to the ventilator changes, discontinue any fluids, discontinue any pressors. By discontinuing pressors before we discontinue the ventilator, we're allowing hypotension to naturally occur. This will allow for a further decrease in patient consciousness and ability to experience respiratory distress. If the patient has sedatives infusing, such as propofol or midazolam, keep those medications infusing during ventilator withdrawal. But note, sedatives do not treat dyspnea, so we will still need to begin a morphine infusion if there isn't already one infusing. I recommend 100 milligrams and 100 cc's and begin it at a basal rate of 1 milligram an hour. When we bolus the patient with morphine before, during, and after withdrawal, I recommend bolusing from the infusion rather than having to go in and out of the patient room to fetch bolus doses. The ventilator withdrawal processes are listed here in descending order. So first, we're going to ascertain consciousness and ability to experience distress at patient baseline. We're going to ascertain the risk for post-extubation stridor. We will determine the need for pre-medication, and we'll pre-medicate those patients that meet that need. We'll be reducing the oxygen and ventilation using one or the other of the two methods. We'll determine the need for oxygen after ventilation is withdrawn, and we'll determine who can be extubated. And it may not be all patients, particularly those succumbing to the COVID-19. So let me elaborate on each of these steps in my subsequent slides. First, we're going to ascertain the risk for post-extubation stridor. This is done by producing a cuff leak by deflating the endotracheal tube cuff, measuring the exhaled tidal volume, calculating the difference between the set tidal volume and the exhaled volume. For example, if the set volume is 300 and the exhaled volume with the cuff deflated is 50, then the difference is 250 cc's. That means there's quite a pronounced cuff leak, and the probability of stridor because of a laryngospasm is small. On the other hand, if the cuff is deflated and the patient is maintaining the tidal volume, so set tidal volume is 300, exhaled tidal volume is 250, the difference is only 50. That patient has experienced laryngospasm when the cuff is deflated and is maintaining the tidal volume, so that patient is at very high risk for post-extubation stridor. Is our patient at high risk for ability to experience distress? We have two measures. We'll look at the RASS, which is the Richmond Agitation Sedation Scale. If the RASS ranges between +4 and -3, the patient is likely to experience distress. But if the RASS is -4 to -5, the patient is unconscious or deeply sedated and unlikely to experience distress. Similarly, we're going to do a baseline measure of the respiratory distress observation scale. And our goal is that the patient is at 3 or less before we make any ventilator changes. Patients who are at risk should be pre-medicated for anticipated dyspnea. So we will use 4 milligrams of morphine as a bolus, 1 milligram of lorazepam, also as an intravenous bolus. These doses can be adjusted to correspond with patient prior use or tolerance. If the patient is receiving fentanyl rather than morphine, fentanyl has a smaller evidence base than morphine for dyspnea treatment. There is no dyspnea evidence for using hydromorphone. Comatose patients do not require pre-medication, although we are going to stand by in case they develop distress during withdrawal and will medicate at that time. For the patient who can experience distress, we're going to employ terminal weaning, and the steps are, as you see illustrated on the slide. We begin with turning off the PEEP, wait a minute or two if there's no respiratory distress, begin to wean the oxygen. Wean by 20% until the patient is at room air oxygen, which is 21%. If there is no respiratory distress, then the ventilator mode is changed to synchronized intermittent mandatory ventilation with pressure support ventilation at SIMV rate 10, pressure support volume 5 centimeters. I use the SIMV mode because patients will still get some preset volume breaths from the ventilator, but are able to take spontaneous breaths at their own spontaneous tidal volume. It's at this stage during weaning that we can ascertain if the patient's breathing is comfortable, and we stagger the reduction in the SIMV to afford the patient the opportunity to become accustomed to natural spontaneous breathing. So reduce by 2 breaths every couple of minutes as long as the patient's RDOS score remains at 3 or less. Once the SIMV rate is at 4, the next step is to turn the ventilator to CPAP 0, pressure support 5. If we are going to disconnect the ventilator from the patient because it's a non-COVID patient, the next step is to turn the ventilator off and disconnect. If the patient has COVID and there's been a decision made to maintain the integrity of the tube through the ventilator circuits to minimize droplet contamination, then you'll leave the patient on CPAP 0, pressure support 5. The patient is spontaneously breathing when they're in the CPAP pressure support mode, but it's a closed circuit. At any point during this weaning process that there's an escalation in the RDOS score, the wean should pause at whatever step you're at so the patient can get a morphine bolus and a period of 5 to 10 minutes for peak effect of that morphine. before continuing with the withdrawal. Since some of these patients may have the adult respiratory distress syndrome, there may need to be a longer interval of recovery of respiratory comfort. In other words, there may need to be more than one morphine bolus to achieve an RDOS score of 3 or less. If the patient is comatose, we can do a one-step reduction from the full settings to CPAP 0, pressure support 5. If the patient is going to be disconnected, then the next step is to turn off the vent and disconnect from the patient. And just as with the weaning patient, we might be maintaining CPAP pressure support through the closed circuit with the ventilator. And just as with the patient able to experience distress, we will still evaluate the RDOS in the comatose patient and medicate if there are signs of respiratory distress. Under normal circumstances, we will extubate patients who pass the cuff leak test and who have a normal tongue size and position in their mouth and who are not hemorrhaging from their lungs. Under the COVID pandemic, we might be maintaining the endotracheal tube as previously stated. Patients are at risk for stridor in the first hour after extubation, and those risk factors are listed on the slide. The treatment for post-extubation stridor is racemic epinephrine as an aerosol treatment, 2.5 milligrams in 3 cc's of normal saline, which may need to be repeated once. We may or may not need this information if the tube is being maintained until the patient dies. When the patient has been weaned and extubated, we need to make a determination about whether or not to use oxygen post-withdrawal. If the O2 saturation is low and the patient is in distress, then do consider adding low-flow oxygen, such as 2 liters by nasal cannula. If the O2 saturation is low, but the patient is in no distress, then oxygen is not needed. If the O2 saturation is normalizing, but the patient is in distress, oxygen will not be helpful, but morphine would be indicated. Ascertaining the need for a continuous morphine infusion after withdrawal is based on how is the patient doing. If it appears that death is imminent, then continue to use bolus dosing. If bolus doses were given and we think the patient is going to live for hours, then you may want to use a continuous infusion dose, particularly if there's evidence of continuing respiratory distress. A continuous infusion dose is achieved by summing the bolus doses, all the doses that were given as pre-medication and to treat distress. Then select your continuous infusion dose by taking half of the summed boluses. So for example, if the patient received 4 milligrams pre-medication and 2 boluses during withdrawal, they received a total of 12 milligrams. So you would set your infusion to 6 milligrams an hour. Titrate to maintain an RDOS at 3 or less by bolusing with morphine 4 milligrams as needed and increasing the hourly rate by 50 to 100%. So that concludes this presentation. I wish you all the best when you are employing these suggestions with your own patients.